Hello, everyone. We'll wait a few more minutes for more people to join. If you can bear with us, thank you. Hello, everyone, and welcome. We're going to wait 1 or 2 more minutes for more people to join. Thank you for your patience. Hello, everyone. We're ready to start in about 1 minute. Thank you for your patience. Okay, good evening, everybody. On behalf of Lumenis and all the panelists, thank you for being here and a big welcome. My name is Paris Hatzi. I'm the Sales and Marketing Director for Lumenis Vision in Europe, Middle East, and Africa. We want to give you a very big thank you for allowing us with us tonight and giving us your time. We have prepared for you a very exciting agenda for the next 2 days, today and tomorrow. We have a lot of exciting material to cover that we hope you're going to find interesting. First off, we have the Dr. Gunnar Gundersen. He's a cataract and refractive surgeon that he's practicing. He's also a private clinic, the only private clinic in his area, actually, in the Haugesund, Norway. I'm not sure if I say that correctly, Haugesund. He's also an expert in dry eye, and tonight he's going to talk to us about the importance of a correct diagnosis and the importance of osmolarity during the dry eye. Following that, we're going to have also Dr. Sergio Solarino. Dr. Solarino is also a refractive and cataract surgeon based in Cagliari, in Sardinia. He's a director of the Clinica Centro Vista, and he's also a dry eye expert. He will be discussing how he actually converted his practice in order to incorporate a dry eye clinic without disrupting his very busy workflow. Last but not last, we're very happy to share with you the very first launch of our Luminous digital showroom. In this VR space, you'll be able to interact with our dry eye solutions and also be able to contact with all of our Luminous experts, us included. At the end of this, the first part of this presentation, you can also receive an email in the next few minutes, a short link that you'll be able to come and visit this VR space. I highly encourage you at your own leisure time to join and actually interact with the systems. And you can also download a vast information from our libraries online. Let me share my screen so you can actually take you a short tour through that space. As soon as you link in, you can come into our booth. You can see the booth, which looks like this. You can actually interact and you can go through the various spaces. The first thing you will be able to see also, you're going to see our Diagnostic Suite. You can actually see the information, read about it, maybe play also an informational video. Let me show you how it is. That will so you'll be able to download all this material. You will also be able to download all the brochures in a digital format if you would like. Most importantly, you'll be able also to see the system, the Optima IPL, and also be able to interact with it. For example, and explore the different handpieces and filters you can see in your disposal. Also, there is a short video that you can actually see the screen. This is very important if you're considering in actually investing in such a solution. You'll be able to go through the different screens of this and see how everything is set up. So this is like having the system, it's like being there actually and experiencing the system as it is. Further on, if you come with me this way, you can actually go into the webinar room where you can have a vast variety of webinars that are already recorded. And as a matter of fact, you can also join the Dr. Gundersen webinar from this link as well, but also from the link that you received through your email. If you follow me this way, you can actually also see some videos, infographics that will give a better understanding of what dry eye is. And as a matter of fact, you can download those videos for your patients. So all this you can actually download at your own time. And if you feel like chatting, you can actually chat with us. We're available at just a click away. So you can actually talk with B. B is our marketing manager. Let's see if she is available to talk. Yeah. So this window is going to open. You can just write your messages here, and B or anybody else can actually will get back to you on real time. So this is a way you can reach out anyone from us at Lumenis at any time, and we can answer any question. Okay. Well, thank you very much, B. It's very nice to be here. All right. So let's move out. Okay. All right. So this is the space. Let me try to give the floor now to Dr. Gundersen. He will be able to discuss also with you if you have any questions. So we're going to have a Q&A session further down after his presentations. So feel free to keep this interactive. Any questions you might have, I'm going to answer. Also, if you want to drop us a question in the chat, we can answer for you also. Okay, and let me stop showing my screen. And I give the floor to Dr. Gundersen.
Yes, Paris. Before starting with Dr. Gundersen, we would like to launch 2 polls related to the digital showroom to hear more about who has already participated in virtual event during this time, because we know that you have been very busy. So we would like to know in how many virtual events have you participated during the last month. You can use the screen to answer. I will wait a couple of more seconds and then we will show the results.
Okay, that's very interesting. So we have 34% actually having attended 2 or 3, and only a quarter of you have attended 4 to 6. Okay.
And we would like to know maybe what they would like to see. on our digital showroom in the upcoming weeks and months, because the digital showroom give us the possibility to keep it at date. So every time you're going to visit in the upcoming days and in the upcoming months, you will find something new to explore.
So please note, this is just still a work in progress. So this is the first iteration of the booth, but we would like to make it as friendly as possible. So please let us know what exactly you would like to see in it.
When we say your avatar, it means that when you arrive on the virtual booth, you have the possibility to build your own avatar and walking through the virtual booth with your avatar.
Okay,
the results
so overwhelming
says
yeah, the overwhelming percent is before and after the dry eye pictures, and this is was expected. This is something that we have will also be working on. Very soon we'll be able to have a before and after of different cases, and as a matter of fact, we have several doctors actually working on some white papers and cases that I think you will find interesting. Very well, great. Thank you very much for answering. Are we ready, B, to go to Dr. Gundersen?
Yeah, we can now move to the presentation of Dr. Gundersen.
Good afternoon, everyone, and welcome to this webinar. I'm going to share my experiences with objective tear film analysis, and the title of my presentation is Objective Tear Film Assessment in Intraocular Surgery, a significant factor for success or failure in this kind of surgery. My name is Kjell Gunner Gundersen. I'm an MD and a PhD working in Haugesund, Norway. This is my clinic located in the center of the city, and I have to disclaim my financial disclosures. I'm consulting for Alcon, Star, First Q, Glaucos, and Centricity. Let me start with a very old saying from Johann Wolfgang von Goethe, the German poet. I saw this picture the first time when I studied medicine in Bonn in Germany, and it says the most difficult thing is what is thought to be the simplest, to really see the things which are before your eyes. And this is something that I will come back to during this presentation. What do we want as surgeons, as ophthalmic surgeons? Of course, we aim to have as many happy patients as possible. And in order to achieve that, there are certain things that we have to bear in mind. We can part it up in three different portions, and that is the preoperative workup, the surgical part, and of course also the postoperative care period. My preoperative protocol. When we start with this, I want to remind you of the ophthalmic anatomy. And when I talk to the patient, I try to illustrate how we are going to proceed, showing them a model of the eye, starting with the ocular surface, which is the front surface of the eye, and then talking a bit about the different structures inside the eye, And then, of course, mentioning the macular anatomy and function, because this is important for the visual prestanda later on. And between ocular surface and the macular function, we have all the biometric measurements that we have to measure ahead of surgery: the corneal topography, the corneal keratometry, the anterior chamber depth, lens thickness, and axial length. And I will come back to this during the presentation. The first part, which we are going to address in this presentation, is the structures involved in the tear production. Tear film consists of 3 different layers: the lipid layer, which is produced by the meibomian glands, which you see here on the eyelids. And there are certain diseases that can affect this. The aqueous layer coming from the lacrimal gland, and of course the mucin layer, which holds this together from the goblet cells in the conjunctiva. And these different diseases can attack different parts of the tear film, which end up in different disease forms. In order to understand the patient's ocular status, there is a lot of tests that has to be done in order to make a good diagnostic preoperative workup. Let's start with the questionnaires. People are not always aware of having an ocular surface problem. So we give them a questionnaire, and the most used are the Osdi questionnaire or the speed questionnaire, which is filled out by the patient. It takes only a few minutes to test that, and that will tell you a bit about how the patients are experiencing their own tear status. Then more objective tests like the tear breakup time, and then different staining procedure is important to map how the cornea and the tear film are functioning. I'm going to talk about Osmolarity Test, which is a measurement of the osmolarity, and hyperosmolarity indicates evaporation of water, leaving us with a very salty surface, which might affect toxic to the patient and to the cornea. I will also talk a bit about the HD analyzer, which is an objective device instrument in order to map the ocular scatter index. Looking at the corneal staining and the conjunctival staining, there is a scientific grading system from very little to very severe disease in order to grade the different stages of this disease. Talking about hyperosmolarity, Tearlab is a commercial available instrument where we can measure the osmolarity in patients. And the normal range is below 300 microosmol per liter, mild between 300 and 320, and moderate and severe is above 320. Besides measuring the osmolarity, if there is a difference between the two eyes or more than 10 to 15 milliosmolar per liter, then we also grade it as abnormal. So this is something that can tell us objectively how the ocular surface is functioning. Another way of making an objective measurement of the osmolarity or the ocular surface disease process or the ocular surface structure is to use the HD analyzer, and this instrument gives us what we call an ocular surface index. In a perfectly normal ocular surface, you will have a low ocular surface index through the whole blink procedure. In a mildly affected eye, you will see that from the first blink until the next blink, the ocular surface index rises, and then you have a blink and you go back to normal again. If you have a severely damaged corneal or ocular surface, it will be up here all the time. And this is a very nice way of documenting ahead of surgery how the patient's ocular surface are functioning. What we did at our clinic was to look at just ordinary cataract patients attending for surgery. And this is the result of a pilot study done 1.5 years ago. And we did all the tests that I've showed you before. And this is the shimmer test, this is osmolarity, this is the breakup time, and this is the questionnaire. And you see that from 30% up to 51%, in this small cohort of patients, they answered positively. So the prevalence of ocular surface disease in this cataract age group is very high. Some form of ocular surface disease is seen in more than 50% in our ordinary cataract patients. So this indicates a very high incidence of this disease, and you have to be aware of that. If we combine and look at the positive tests, there are in more than 55% of these 97 patients, we found two or three more, more than 2 positive tests. And all of these positive tests, 52 reported no symptoms. So in this regard, we have to bear in mind there is a large group of false positives and also false negatives. So only to ask the patients for symptoms, you will miss half of these patients. So you have to combine subjective with objective tests in order to catch these patients. So to conclude this pilot study, the calculated prevalence of dry eye presenting for cataract surgery varied with test method. Subjective testing appeared to produce the lowest estimate of prevalence of dry eye, which may be a function of reduced corneal sensitivity with age. Objective tests suggest that the high percentage, more than 50% of patients presenting for cataract surgery have a dry eye disease or an ocular surface disorder. So for all those of you that perform cataract surgery, I urge you to include objective dry eye testing in all patients presenting for cataract surgery. What will happen if you miss it? One of the ahead of surgery, we have to do biometry testing. And one of the most sensitive tests when you have ocular surface disease is the keratometric measurements. In a study performed by Potvin et al., they found that if you had a hyperosmolarity situation, you could have up to 2.5 diopters of keratometric variability in the same patient. And if that uncertainty or variability is brought into your biometric formulas, you can end up with a refractive miss of up to 2 diopters of refractive miss. Within this, during the surgery, if you have a correct biometry and correct preoperative medication, Then surgical is about optimal instrumentation, use as low ultrasound energy as possible, and from my point of view, using the correct IOL. If you measure toricity, I urge you to correct it with toric IOLs, and I strongly believe that patients should be presented to an IOL choice if they want multifocals or EDOF lenses. They should know that this is possible and be offered this as a co-payment if necessary. When we look at the post-operative protocol, how do we follow these patients after surgery? Of course, what the patient sees is for the patients the most important parameter. So their post-operative refraction and what they see with this refraction is for the patient the most important thing. Of course, we ask them for subjective symptoms. Do they have pain? Do they have itching? Do they have other symptoms? And if we can find objective and subjective signs of ocular surface disease, then we have to introduce and continue treatment in these patients. Because if you provide them with ocular surface, the correct ocular surface treatment, the patients will feel better and they will see better. So to sum up, ocular surface is an important and frequent factor for surgical success or failure, subjectively as well as objectively. Ocular surface disorder has to be identified ahead of surgery, otherwise the surgeon and the surgery will be blamed. Optimal treatment should be initiated ahead of surgery and continued after surgery, maybe for life. An optimal ocular surface treatment will make the patients both feel better and see better. I started with Goethe and I will end with Goethe. To think is easy, to act is difficult. To act as one thinks is the most difficult part. We have to utilize what we have learned in daily life practice in order to help our patients for optimal post-operative results. Thank you for your attention.
Thank you very much, Dr. Gundersen. We are going to host the Q&A session in less than 1 hour. So I invite everyone who has a question to use the question panel or the chat panel, and we will read all the questions during the Q&A session. We now move to the next session. We have Dr. Solarino, who is going to talk why he considered the Optima IPL having the best ROI in the market.
Hi. Hello, everybody. I am Dr. Sergio Solarino, and I live in Cagliari, Italy. And today I will talk about the Optima IPL system and why, in my opinion, it has the fastest ROI in the market. We will not talk about the clinical results, but we will focus on the way to make this system work for earning and make it work. Okay. And we will talk about how to become the dry eye guy of your area, and also how to organize your pipeline for boosting the bottom line in your office. So we will analyze what happens usually in your office, in your waiting room, and we will discover why this system can make you get the fastest ROI. So I must thank you for being here to listen to my presentation. It has been a very challenging working here. We know that with the problem everywhere known of the COVID-19, this situation showed us the need to work harder and better to recover the time we lost in the lockdown period. We are facing the problem how to improve our earnings actually for the end of this particular, and especially what are the best tips for recruiting your team doctors or for make them work harder for IPL therapy on dry eye patients. For doing this, we must understand very well the recent story, mostly about the dry eye diagnosis. If we want to evolve, we must learn from the mistakes we made in the past. So years ago, the dry eye diagnosis was based on a few clinical examinations, and the majority of ophthalmologists thought that both diagnosis and the therapy was boring and unsuccessful most of the time. All of this has relegated the dry eye disease to a restricted and unsuccessful pipeline. So much effort and so little success. This is what the doctor was thinking about the dry eye patients and the dry eye treatments. So dry eye patient was seen like a boring patient, someone who was never satisfied or everything we can do. So do we were used to get poor results? Is it true? So much effort and so little success? This is what we doctors were thinking about treating dry eye patients. And also the patient perception about this problem wasn't far from that. But we usually were not explaining too much to patients about their condition. And the patient didn't know really what happens to their eyes. They only know to the need of putting drops in their eyes for a long time, maybe for all their life, without any possibility to recover completely from that need. So it's not strange that dry eye disease and related discomfort syndrome have remained unsolved for years. So many efforts and bad results. The therapy consisted of a large amount of eye drops and many things to do, like keeping warm the eyelids, like scrubbing the surface of the eyelid, and many other things that was very boring also for the patient. Often the patient, although starting the therapy, gradually tapered off, often completely stopping it. The results depend too much on the patient compliance alone. And usually also we ophthalmologists were thinking that this problem, the dry eye disease, was something for super experts, for scientists that were busy staining the tears, scraping the eyelid margin, and so on. Something that was very time consuming in our pipeline, and with poor results also for knowing what was happening really to the surface, the eye surface of the patients. At this time, it was really a topic for super experts. This is only partially true, actually. Years ago, a task force of a super specialized ophthalmologist was able to build an efficient diagnostic pipeline to detect dry eye disease. And that would lead to a better understanding of this pathology. Actually, we can perform a very important list of exams on the eye surface, a premium quality dry eye diagnostic. So talking about nowadays, how can we understand better how to become expert in this particular field and get the market move very fast? I think the main problem in the past was that we were treating only the symptoms of the dry eye. So we can get out of the vicious cycle. Actually, with the IPL system, we can treat the cause of the problems. So the cause of dry eye will be cut, and probably we will get more satisfaction from that kind of therapy. And the patients also know very fast that something is moving backwards when they has less problems, less pain, less foreign body sensation. So they are moving faster in a better situation. They feel. And treating the cause is a very important thing that we must explain. Losing time to explain this to patients because they don't know exactly what happens to their eyes. They were used to put only drops. We must explain them that we are not treating only the symptoms, but we are treating the cause. We are ending the vicious cycle of the dry eye. So it will take time. We must explain also this, but we are going to a different direction. It's very important that the patient know that something has changed. We are treating the cause. The second thing that is changing is how we can obtain better results in terms of time, because the results appears faster. Sometimes the patient call you or text you after 2 times that you use the IPL system. So they will text you that, oh wow, everything is better than the previous month. Actually, I'm sleeping without drops or something like this. So they are very enthusiastic sometimes of the results. The evidence of those results is rapidly perceived by the patients, and this confirm how the patient will continue to be treated. They want to be treated because they feel really better. The patient consciousness is very, very important. The pre-treatment test that we made on them is very important because is the main point of a paragon between the pre and post treatment periods. So it's very important that the patient know exactly which is the situation he has for like starting situation. So it's very important that he know and he understand how is bad is starting. And when patients think about the past, only made of drops of tears substitute, they must know that is real. This one, the IPL system, the Optima IPL system is a real treatment, and they will get real satisfaction. So Optima IPL is the real thing, is here to stay and to perform well for the next time. We actually know that we have two sides of the same problem that are going to be better than ever before. Better patient satisfaction means less frustration for the physician, and usually one thing that we really know well in our office is that every patient is completely different from another. But sometimes, particularly for the dry eye disease, we made the mistake in the past to consider everyone similar to another for this kind of disease. So we must understand better which is the situation, the starting situation of those patients. We must understand how they differ one from the other. We must understand that they are patients that are chronic, so they will be with us for probably, they differ for timing because they are chronic patient for a chronic treatment. If we consider other patients like cataract patient, like refractive surgery patient, we know that they always generate a very short time follow-up because we only see those patients for the pre-op considerations and visit and evaluation of the IOL, the refractive defect. So they will be operated and the 3, 4, 5 control after the operation, and the patient is okay and he will be back to his normal life. Usually, patients with dry eye disease are different. They are different because they are the chronic patient, so they need to be treated for many years sometimes. So dry eye patient need chronic treatment. Dry eye disease is different. We can say that the dry eye patient need more follow-up, and in some cases they never stop undergoing booster treatments for years. They are more frequently demanding patient. They need more explanation. They need explanation about changing the therapy because they must understand that we are not in a doubt of which therapy to use, but we are planning a different therapy for the different situation between one treatment and the other. So sometimes they depend psychologically from the dry eye center, and we must understand. At this point, we must also talk about the numbers because numbers really matters in our activity. And we know that the first year, those patients usually are treated and undergo IPL treatment at least once every 4 weeks for the first 4 to 6 month period. Usually the first one is separated from the second one only with 2 weeks, a 2 weeks period beneath the first and the second treatment. Then about 4 weeks from one treatment. So talking about the numbers, we can also think about the following years. We can easily understand that one diagnosed patient is adding at least 1 or 2 treatments a year for the following years, because we must see how he develop the new situation. And sometimes during the winter mainly, we can treat him each year 1 or 2 times. Thinking about revenue calculation in dry eye disease treatment, we must understand and think that also the recruiting of some particular kind of patients, like refractive surgery patient, can be really boosted from this kind of treatment, because sometimes we have a patient that are not allowed to undergo refractive surgery due to their particular severe dry eye situation. We can say that IPL is currently the only treatment that it is capable of transforming such previously inoperable patient into operable cases of refractive surgery. Obviously, in those cases, we usually to perform some treatment before the operation, the LASIK operation, but we continue after that for a longer period of time to make them recover a better surface situation after. Usually, patients that undergone a refractive surgery treatment would like to have the better visual acuity. And we know that these can carry a good patient satisfaction. So we know also that the tear films is very crucial for visual acuity after the refractive surgery. So treating the patient for the dry eye contribute exactly to get the better visual acuity after the operation, the postoperative. Another branch of the tree that in my pipeline is growing very fast are cataract patients, mainly premium lens cataract patients because they are really high demanding. Usually those people are in the 60s or 80s decade of their life, and we usually know that in these decades the dry eye is very high represented. So after the cataract, some poor results can be correlated to main symptoms like a blurred vision after the ending of the therapy. And also the pain, the sensation of foreign body in the presumed site of the incision. They say that in this part of the eye, I can feel like there is a sand each morning when I get out of the bed. So they are complaining about this for months. Usually, if we do perform a dry eye evaluation, we can say that those patients are dry eye patients, and we can treat them and get well soon them from this problem with IPL treatment. So more patient satisfaction also in cataract patient, in a premium lenses patient, also with a better visual acuity. So we saw that many patients has a dry eye, many patients can get a better situation for getting an operation and better results from this. But one of the things that I thought since the very beginning is that dry eye patient has a very low consciousness about their problems. So usually before the advent of the IPL, they were treated only with drops. So sometimes they are complaining before drops prescription that they have excessive tearing. So it was quite challenging make them understand that at the origin of the profuse tearing was the lack of superficial lipidic tear film. So it was for them quite impossible to understand why we add artificial tears while they are still tearing when they have many light in the room, or when they stay in the sunlight or something like this. It was a quite challenging thing to explain them. We need a method to make them increase their consciousness of their own illness. So we are not only explaining a thing. We need that they write something. They answer to question and put it down in a sheet of paper, because that will be the start position from the treating with the IPL. Is a self-evaluation test. We usually use the Osdi self-test, and for the first time in this situation, the patient will be himself that will evaluate his own condition. This makes a big difference, because for the first time he will be the judge of his situation, and all will be recorded and filed to compare for future performances after the treatment. And this is very, very important because a patient can be can see exactly what they put it down during the first examination, the first test, self-test, and compare directly what they were suffering in that period. I think this test, this self-test, is really important. Is fundamental because is the patient will, is his testament, is the place where he declares all his symptoms and the grade of his disease by himself. So it's very, very important because after this he will going to understand better everything will happen after this. Sometimes they say that before this they even didn't know how much the dry eye was relevant in all days life in many areas of their life, like driving, see television. And after this self-evaluation test, I think it's very important, the initial talk, as I call it, is the moment in which we explain directly the test to the patient and in which we'll understand better which is the strategy, which is the problem that he has about the lipid layer, all the other things that are analyzed by the test. And in this situation, the patient admit symptoms and the wrong behaviors more easily. So it's more easy to make them to change their behaviors and understand the therapy. So we can easily say that to build satisfaction, we need to be. And in the initial talk, we needed to create the right time perspective and expectation. We must explain that this is not a one-shot treatment. They need probably to make 1, 2, 3, 4 treatments the first year, probably 1 or 2 the second year, and the third year. So that is a treatment that will last for a long time. We must remind that the dry eye disease patient differ from cataract patient, refractive surgery patient. They are not usually patients that are wow patient. The day after, they can be more happy about their situation, but it's different from the cataract patient that the day before the surgery doesn't see anything, and the day after they see double, 4 times or 5 times more than they was used to see before the operation. Also, the refractive surgery, we know that it is a patient that is very satisfied in a short time after surgery. So this is must kept in mind that all those patients are very different from refractive or cataract. So we are not searching a wow effect like cataract or refractive surgery patient, but we know we must explain to the dry eye disease patient that his condition will improve gradually, that he will be in need to plan more time to reach appreciable improvements in his case. And this is very important. In the initial talk, we must explain to the patient, must inform him that he is starting the backwards journey in his aging and worsening of his tears function. So it will take time. Another thing that we can explain is that there is a positive effect also on the treated areas in his face. And this should be emphasized because usually patients do appreciate this very much. We talked about dry eye disease consciousness, dry eye disease numbers. Now, let's think about our waiting room. How is our patient population composed in our waiting room? If we open the door of our waiting room of a medium busy day, which kind of patients are seated over there? Usually, I can say that in my waiting room, about 40% are cataract, pre or post-op, 20% probably are refractive patient, 50% glaucoma patient, chronic patient in other words, 10% macula or retina patient, and a mix remaining is about 15%. So this is our mean composition when we open the door. And this is a point for starting our ideas about how build the pipeline for treating dry eye disease, for detecting, analyzing what I said before about the percentage of a patient with their kind of problems. We can say that in red, we see those patients that are probably they suffering some degree of dry eye disease. Cataract patient, mainly because they are usually old, refractive patient because their refractive surgery is a challenging surgery for the ocular surface. And glaucoma patient because they are usually old, usually chronically administrating drops, sometimes very easy to get a reaction of ocular surface. It's less probably that a macular retina patient has some kind of some degree of dry eye disease because they can have a macula or retina problems in, diciamo, we can say in the old 70s, 80s, and probably only for these, but it's not usually something in which we can administrate drops like a glaucoma or something like this. So if we do a calculation about our waiting room and our patient, we can easily say that the vast majority of my patient, I think also your patients, can be evaluated for dry eyes. Obviously, we are not expecting that all those patients has the same degree of dry eyes, but probably if we can add the cataract patient to refractive and then to glaucoma patient, we get about 75% of people that has some degree of dry eye disease. And this is something that is very, very... If we talk, for example, about a glaucoma patient, as we told before, the glaucoma patient is a chronic patient from the very beginning. His therapy is usually topical and increases intensity and frequencies over the years, thus obtaining a moderate or severe dry eye syndrome in the majority when not in all of them. Dry eye worsens the absorption of the therapy, and also visual acuity is worse. Pain and discomfort are also related to the dry eye. So these are patients very important for the dry eye test and the dry eye treatment. So let's make some calculation in our waiting room. we can calculate that if one physician is visiting 50 patients a week, about 37 of them probably are suffering from some form of dry eye disease. And if only the 10% of these 37, in other words, 3.7 people would adhere to IPL therapy, we will be the total of 3.7 for 4 weeks for month. That is 14.8 patients a month. Then if we multiply these for 10 months for of year activity, we can say that we can screen 148 patients a year. Each of them will undergo a mean of 3 treatments a year, then about 447 treatments. If we charge 200 euros, it will be 89,400 euros. If we charge less, 150, we can earn 767,050 euros. So a lot of money with a very few people, because we are only calculating 10% of the people that can suffer some form of dry eye. So we just needed the 10% of these patients in our waiting room. And these are the calculations we made before. Each of them will undergo an average of 3 treatments a year, 447 treatments. It means from about 90,000 to about 70,000 euros a year. Now we know that it is very important to detect those patients, and we know that it is important to act like all the patients have some form of the dry eye disease. So diagnostic is very, very important, because diagnostic path can be easily conducted by, in Italy, orthotista, that is an ophthalmologist dedicated assistant, or by optician in other countries other than Italy. Actually, the treatments remain in medical hands in the majority of European countries, but there are countries in Europe in which optician can treat also patients with eye. The diagnostic tool must be the premium diagnostic tools, the better we can do, because we must explain to the patient, as we told, we must have something to compare in the future. So it's very important to understand better the situation that the patient can have in his starting period. So accurate medical history, the Osdi Questionnaire, the objective examination to detect blepharitis, Demodex, rosacea, ocular redness classification, non-invasive breakup time test, the interferometry, the tear meniscus, the mammography, the average number of winks that the patient can perform, the completeness of the winking. All those are very important to understand the patient condition, to explain which are the problems to each patient, and make them be more aware about. We already talked about the Osdi, and in this case, the patient can see easily which is the grade of his problems. So it's very important to make them understand, to make them see. Also to explain them the ocular redness classification. If we took photographs of the eye or video of the eye, we can explain them better. I think it's also important to explain to the patient the tear meniscus and how it correlates to dry eye symptoms that is suffering. Interferometry is one of the main exam that must be explained to patient to understand that is the meibomian gland that is responsible for the thickness of lipid layer of the tears, and this is very important because the only part that we can really improve with the IPL treatment. Lipid layer is very important. We know against the tears film evaporation, how is built and organized is very. And actually also the meibography is a fundamental examination, and is quite easy to explain to the patient how is their own situation, because it's very easy to understand how the lacrimal gland or the meibomian gland are alterated in their anatomical position or quantity of length. Again, the meibography of the inferior and this is an examination of the non-invasive Bergkap time. We see the circles that will corrupt in some place and will begin to break, and like this. And this is also easy to as recording the examination, we can easily explain to patient how examination is made and how can the situation can be wrong, very far from the norm. Now we know that we can make a good diagnosis, that we have beautiful tests for the dry eye, that we can treat patient with the best IPL system on the market, and we need to generate echo to make all the people around us known that we are treating those patients and obtaining results. How we can reach all those patients, those potential patients? We must explain this to our staff. We can use many channels, so advertising, trying to build co-manage the relationship, like relationship with opticians, rheumatologists, neurologists, other people that are interested in the dry eye disease. Increasing or building a medical ophthalmological consciousness about this, making dry eye class, dry eye day, in which we can explain to people, to dry eye patients, which are our treatment option and the diagnosis option that can fit to them, to their problems. Here we can see an advertising. It's very important, I think, to advertise what we are doing. In this case, is with the best machine another advertising video. Okay, so we reached the end of the presentation. I hope you appreciate our presentation and will better understand the IPL treatment with the Lumenis. In conclusion, we must go straight to the heart. We let people know IPL is here to stay and it works. We make a physician understand how easy is both success and make money with this IPL system. So thank you very much for listening to my presentation. Bye-bye.
Thank you very much, Dr. Solarino. Before we move to the Q&A session, we are launching the last two polls for today. We invite all the attendees to engage with us. We would like to know which is the preferred method that you use in your clinic to treat dry eye. So it's drops, it's IPL, or it's thermal compresses.
Wow, this is interesting. I bet that if we had these questions 5-6 years ago, the results would be completely different. So I think people understand that compliance is an issue, and patients feel better by having more stable methods of treating. Very interesting. The second.
Let's move to the last one. Yes. How would you rate the initial consultation with a patient for setting expectation? It's very important for you, important or not so important?
Okay, very important. I assume that many of you agree this disease is as psychological as it is physiological. So setting expectations for somebody that is suffering for many years, I believe it's very important. Interesting stuff. Great. Thank you, B.
Thank you, everyone. We are going to ask now Dr. Gundersen and Dr. Solarino to answer your question. I will enable their audio and video. Hello, Dr. Gundersen. Good evening. Can you hear me?
You are mute, probably, Dr. Anderson.
We will try to, okay. We can see both Dr. Solarino and Dr. Gundersen, but I'm not sure that they are able to speak. Still not? Okay, let's try.
I'm physically unmuted. Can you hear me?
Yes, now we can hear you.
Okay.
Hello, good evening,
Hello.
and thanks for having dedicated some times and joining the Dry Eye Summit organized by Lumenis.
Okay, can you hear me now?
Yes, we can hear you, Dr. Solarino.
Okay,
thank you very much.
Hi, Dr. Gundersen. Hi.
Hello, nice to meet you.
Nice to meet you too.
And it's snow outside my window.
Oh, wow. I think here outside is completely different because we have 14 degrees, so Sardinia is not so cold, but I like very much the snow.
Okay, I already have received some questions. I invite everyone again to make their own question using the chat panel or raise their hand. We will enable your microphone if you want to speak directly to the doctors. I would like to start with the first question I've got related to Dr. Gundersen's presentation. So they are asking about the osmolarity test. They would like to ask if and when patients get back to the normal osmolarity.
Let's say osmolarity tests is, from my point of view, a very important test to do because it's objective. Patients may have symptoms from the dry eye or they may not. And osmolarity test really gives you an objective information about how the surface is, the evaporation status of the eye. So when you treat patients being hyperosmolar from the beginning, you will see a slowly normalization of their osmolarity status. So you can use the osmolarity test as a diagnostic tool, but also to follow therapy over time.
Thank you. The next question is about the IPL. So they're asking if they can make more than 4 consecutive IPL in the first treatment year. And when does a patient usually come back after the first year treatment?
This is for Dr. Solarino?
Yes,
this is
for
me?
Dr.
Okay,
Solarino.
thank you so much. I didn't understood. So I think that usually we say that 4 treatments are the medium treatments that we think to act on the patient. But you know, dry eye disease is not a standard disease for everybody. We have such different things in front of us when we saw patients. So we must understand that we have to complete those treatments with the expression of meibomian glands. Sometimes we do not that. So obviously we try to standardize. So at first, the first treatment, after 15 days, the second one, then each 4 weeks about other 3 or 4 treatments. But there is not a standard that is a frozen standard. We can adapt these to the patient. And usually the patient, you know, don't say us that everything is going well at the second treatment. So we must wait, but sometimes they began to understand that everything is working in the right direction at the third, the fourth treatment. And more, you know that not everybody has a evaporative problem. So in that case, is more useful to go further with the treatments and see if they can change something in those patients, maybe 5 or more. Another thing is important is to made the recall treatments in the second year, because usually patient forget to do something that is important, like wear glasses for near, other things like this that can worsen again his problems. So we have to treat them once more in the second year, maybe 1 or 2 times as a recall. That's in my opinion, actually.
Thank you. And we have one more question for you, Dr. Solarino. Is it possible to make IPL on mole on the skin?
Yes, I think it's possible. We know that there is a good influence of IPL on this problem, but obviously we are not going to resolve the mole with the IPL. We can do that, but is not a resolutive problem. Mole usually must be treated differently, but we can also do the treatment over there.
Thank you. And one question for Dr. Gundersen. Is osmolarity alone a proponent for dry eye disease?
No. Dry eye disease is a multifactorial disease, and like my colleague Solarino very nicely described it, there are no such thing as a standard dry eye patient. So everyone has to be diagnosed and treated separately or individually. So osmolarity tests is a part of the objective diagnostics, but you have to add questionnaires, you have to add the standard diagnostic methods like shimmer and tear breakup and everything. So there is no quick fix regarding treatment, and there are no quick fix from the diagnosis. You have to consider several factors in order to establish a proper diagnosis. And this is probably the most important hurdle for most of our colleagues, that they want to have an answer in 1 or 2 tests, and that is more or less impossible with today's technology. I would really like to have something that I could just push the button and have a clear diagnosis, but this is not the real situation. We have to use our heads and combine different diagnostics and therapeutics modalities in order to treat these patients. And my colleague also pointed out a very important factor in this patient cohort, and that is patience and a long time. So you have to have a perspective that lasts for years and maybe for lifetime. There are no one single treatment and then you can leave them for forever. These patients will follow you. You have to follow them for years, and with time you may reduce the need for visits, but you will need to see them at least once to twice a year. That is my opinion.
I totally agree.
Thank you for the clarification. And we move back to Dr. Solarino for a question on IPL. How is the IPL treatment perform, and how much time it requires?
How much time a single treatment is it? This is the question. I think it's very fast, the single treatment. You know, I usually perform a double passage on the face of the patient, and sometimes I do extend not only in the malar part but also in the other part, especially obviously in females. And I think this can be accelerating the recovery of the patient from the initial symptoms. But you know, as my colleague Dr. Gundersen told before, we must be aware that also if we think is a standard, is not a standard. So we have to begin the journey about this journey is the journey backwards. Is that the patient made in the wrong direction in many years, so we need time to obtain some results. The more comforting things is that the first results is clear in the mind of a patient quite rapidly. In the second, third treatment, they can say us, I'm feeling better now in the morning, late at night, I'm feeling better. And this is very important because make them very convinced to continue the treatments, and knowing that this time this is working. It's not like only the drops, you know, they don't trust probably anymore, because in many years they didn't change completely their situation, their clinical situation, their symptoms. So it's fast, but you need time.
Okay, that's clear. And also, Dr. Solarino, how do you compare Lumenis Optima IPL with other competitor offering the IPL technology in the market?
Ah, wow, this is a key question, because you know, I tried other system before, and I saw that the difference. I understood that the difference when I began to treat the people with the Lumenis, because before I thought every system was quite equal. Now I know that it's completely different, because I see the results that are completely different. One of the main important things is the possibility to have always your setting. Also, if we are treating many patients one after the other, the machine is not changing its delivery of the energy. So this is very, very important. If you choose one energy, one repetition time, to have the possibility to obtain always the same that you choose. And this is not common in other systems. And also the other possibility, I think, is that we can choose many other options to go into the aesthetic field. So this is a machine that can grow with your office activity. So is a very, very important difference between Lumenis and all the other systems. We know that Lumenis was the first to invented the IPL, and all the other follows. So we must understand easily that this matter. This is the real thing. This is the thing that works.
Thank you. We have one question for the Osdi Questionnaire for Dr. Gundersen. How often do you test the Osdi Questionnaire, and what do you base the frequency?
OSDI questionnaire is mostly used, let's say we have several studies going on at our clinic, and then we use it systematically, not only in the preoperative or the first tests. We use it as a treatment guidance tool as well. But in the clinical settings, let's say ahead of standard cataract surgery, we use it primarily in the preoperative evaluation of the patients. And that is the reason why we use it is patient education. It's doctor education, but it is also patient education, because there is a lot of patients that are unaware of their dry eye disease. And that might also have a lot of reasons. Some of them are that the disease is so heavy that they have lost sensation, and therefore are not feeling very much from the dry eye disease, although the dry eye disease might be very severe, and that might also give you another difficult position, because when you start treating these patients, then they get their sensation back and may feel worse than they did in the beginning. So this is a paradox. If you have very bad patients from the beginning, then you have to tell them and educate them. Then during the first phase of treatment, they might get worse before they get better again. So again, what I said in one of the previous questions, there are no quick fix solutions for nothing. You have to be patient. You have to be a teacher towards your patient and follow them over a long period of time in order to guide them through their disease stages.
Thanks. Moving back to Dr. Solarino, do you recommend some kind of in-home treatment therapy as a conjunction to the IPL?
I beg your pardon, I recommend what?
Some kind of in-home treatment therapy as a conjunction to the IPL treatment.
I actually try to recommend different things for different patients. So we can see that someone has is in need of dexamethasone or antibiotic in the first time because there is a lead margin problems. So we can add more treatments and change them. I think one important thing to explain at the start of the therapy, make the patient understand that we will change the therapy each time in depend of what we see is developing the new situation, because the patients are coming from many years of changing therapies, so they can think that we are not comfortable with the previous therapy. We don't know exactly what to do, so we are changing because we don't know how obtain what we want. But the thing is completely different. We have the need to change therapy during a longer period, like 1 year, 2 years. The patient is treated. So we are in the position that we must explain these at first, and the patient know that we can add the therapy in depending of what we see in his situation time by time.
Okay, thanks. And do you now see more patients having IPL treatment due to the fact that they are wearing the mask due to the COVID-19 situation?
I didn't understood exactly the question.
Sorry. Do you have more patients in the IPL treatment now with people wearing masks?
No, not actually, we are not making the people wearing a mask for thermic treatment anymore, because I think this is needed when you do not express the meibomian gland. But we are adding this manual expression, the meibomian gland, during the previous, the first, the second, the third treatment. So we are trying to make the glands works and start again to express their production meibium. So I think this is important to do that during the treatment, not at home. I don't think this is working so much. Probably if you spend less time doing gland expression at the operating theater, you are more in need to use thermal compresses on the eye and something like these masks.
Thank you. And I have one question for Dr. Gundersen. What do you do when breakup time and meibography show MGD but osmolarity not?
Let's say if we find that we have abnormal findings one diagnostic test alone is not enough to decide whatever you want to do. But let's say a normal osmolarity means something. But if you find that they have meibomian glands that are compromised, if you find other signs of pathology, blepharitis or whatever, of course we have to treat that underlying disease. We pointed that out, both colleague Solarino and myself, that this is a multifactorial disease, and you cannot isolate one part of it or the other. You have to consider all respects. So if you find pathologies, let's say in the osmolarity basis, it's more telling you something about the evaporation status of the patient. So if they have a lot of evaporation, the osmolarity goes high. Then you have to substitute that and to balance the salt concentration and avoid that toxicity that produces. If you find pathologies in the meibomian gland, then treat them with expression, with IPL, with lippy flow, or whatever you choose to use, but in order to get that flow again. And of course, if you have a lot of other signs of inflammation, then you have to treat them with anti-inflammatory agents like Icaris, like local steroid drops or whatever. So being multifactorial, we have to treat that the factors that you can diagnose, and with time that will normalize the status. And then you can use both the osmolarity test, the Osdi test, and other tests in order to confirm that you are on the right track with the patients, together with the subjective feedback that you get from the patient.
Thank you. I have another question for you. What is your opinion in testing for inflammatory agents like MMP9?
I think to be brutally honest, we don't know exactly how this is. We know that inflammation is a very important part of dry eye disease, because both short-term therapy and long-term therapy with Icaris, for instance, really shows us that we can improve this status. But I don't think we have established the proper place of these diagnostic tests. I think we know more, we need more clinical science in order to be sure what kind of test we should use and how we should interpret it over the time. But of course, if you go if you look for inflammation, then you can look at staining, for instance. If you have a very high degree of staining in the beginning and you treat them with anti-inflammatory agents, you will see that staining slowly improves, and that will be a clinical sign that you can follow during therapy.
Thank you. And we have one question for both of you. How do you convince a symptomatic patient that they need treatment?
Should I start?
Yeah, sure. You do.
So you asked how do you deal with an asymptomatic patient or a symptomatic?
Asymptomatic.
Asymptomatic. Okay.
Yeah.
If they have symptoms, then of course you are in the best position, because then you can use your clinical skills, your examination methods, in order to look for a reason why they have symptoms. And if you find either a meibomian gland dysfunction or staining or whatever, you show it to the patient, because this is all about understanding your symptoms. And if the patient can understand the symptoms, they will tolerate and be motivated for the treatment. And with treatment, which hopefully will lead to an improvement of the disease, then you can show them the improvement, and you get a good relation to the patients. And in the dry eye disease group, this is really the crucial spot. If you are not able to involve yourself as a doctor or as a professional towards your patients in that one-to-one situation, then it's going to be hard to follow these patients.
Yes, I totally agree. If it's my time to answer with what said Dr. Gundersen, because you know, the symptomatic people sometimes are not the worst people. We see that young people sometimes has an Osdi test that is dramatic with a great perception of problems in the eye. But when we do analyze the eye of those young people, we don't find so much things as they actually feel. In the opposite situation, sometimes there are older people that has a very terrific surface, because you see that they even can see well because they have a very poor lipidic film, a very poor tear on the surface of the corneal surface, but they don't feel quite anything because they lose all their receptors. Actually, also, even though the situation is dramatic, they don't complain so much about their situation. They don't feel pain so much. So we must understand that the things is right in the middle. We must see what the people feel and also compare with the objective examination that tell us everything what is really happening in the eye. And one of the things that we must keep in mind is that also worsening in the tear problems is a journey. So they start maybe when they began to wear contact lenses in a wrong way, too much time. They don't clean the lid margin for many years, and they began to go in the wrong direction. Then after 10 years, people don't usually use contact lens anymore. But why? Because they started a long time before to have problems that at the beginning were very small problems, but these problems began to grow, and actually when you see them, they have the problem that can make them not possible anymore to wear contact lenses, or they feel pain in the eye, or they feel problems because they have a blurred vision. So we must consider everything, because it's a journey in one direction, and we have to start the journey in the opposite direction. So we need the time. We can see patients that feel very complaining about their situation, or sometimes they feel quite normal in spite of a very bad surface. So we have to compare, I think. Asymptomatic is not a term that completely describes the patient. We must see if really he is asymptomatic, if actually there is something that we can improve. So even though you don't know that he has problems, if we can improve his vision, if his feeling, probably there is a symptoms that is underestimated by the patient, but probably is not completely asymptomatic.
Great, thank you.
Let me add some, just a clinical example, and that is, since I'm a cataract and refractive surgeon and do a lot of cataract, so if I go 5 to 10 years back, we had this 5 to 10% patients that were not satisfied after surgery, and we didn't realize why they were not satisfied. And my qualified guess now, after digging into the dry eye problem, is that a majority of these patients complaining after uncomplicated, perfect surgery had something in the tear film ahead of surgery, which we didn't see, And when they appeared after surgery, they blamed the surgery. So not only there is a very important, as cataract surgeons or intraocular surgeons, it's important to bear that in mind, that look for this disease ahead of surgery. If you don't, you will be blamed after surgery. And it's even though the surgery has nothing to do with the cause of the disease at all. But it's about covering your ass as well.
Sure. Exactly.
Thank you both. That was an amazing webinar for both of you, and thank you for the wealth of information. With that note, we're finishing today's session. Thank you all for attending. Please make sure that you use the link that we send you, so you can visit our booth at any time at your leisure. You can experience the 3D version of the system. And we hope we're going to see you tomorrow at the same time. Tomorrow we have also an exciting program. Dr. Rolando Toyos will discuss advanced IPL treatments. And then we have Dr. Alejandro Alba from Spain. He will actually discuss how a proper diagnostic pipeline is important to combat this disease. Thank you very much for everybody, and have a good night. Thank you.
Thank
Bye-bye.
you. Hi, Paris.
Thank you very much. Bye.
Bye-bye. Bye-bye, Dr. Gundersen. Bye.
Bye-bye.